Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Charan K. Singh, MD. Dr. Charan Singh is a neurologist at Washington Hospital. Dr. Singh graduated from medical school at MBBS Lady Hardinge Medical College in India. She conducted her internship at Highland Hospital in Oakland and her residency and fellowship at Stanford University Medical Center. Dr. Singh is board certified in neurology.
Good afternoon, and thank you all for being here. Before I start the talk, I wanted to know how many of you have the diagnosis of Alzheimer's? Half, okay. And how many of you are caregivers? The reason I ask this is because whatever I'm going to say, I just want you all to know doesn't necessarily pertain to everybody. You'll hear things that may sound horrendous, which may not pertain to you. You'll hear things where I have to give you the whole gamut of Alzheimer's disease, its various manifestations in memory, in personality, in behavior patterns. If you don't have it, you don't have to have it. I just want to make that right clear, because I don't want you to go from this talk feeling uncomfortable or feeling like, you know, this is where I'm headed and this is horrible, or this is where I'm headed and there is no hope for me. I don't want you to go back with that. I do want you to get a perspective, however, of the different things that can happen. And I do want you to get to know that everybody is individually variable. We can't really make blanket statements. I can't say all 50 of my patients with Alzheimer's will have this kind of a symptom complex. And I cannot also predict how a particular patient or how a particular individual will do with time, okay? I really want you to take that home first. So I'm here to talk about Alzheimer's disease or Alzheimer's dementia. Dementia being the Latin term which just means memory problems. And Alzheimer's disease diagnosis was first made and written about in 1906, so it's been around for more than a century. A German psychiatrist and neuropathologist actually diagnosed it in a 50-year-old woman who presented with not only memory problems but also personality changes. And he then went on to do pathology and found certain changes in the brain that we still see to this day. And then there were other people who wrote about it, but it was then in the 1970s and 80s and especially the 90s where the diagnosis and the treatment thereof has become more possible. More and more research is being done. There are now 400 new drugs that are in trials, phase 3 trials, of which some will come to fruition. The problem with Alzheimer's is we still, 106 years later, don't know the etiology, meaning what causes it. We still don't know if what we think causes it really is the one that's causing it. And therefore, whatever drugs that we are introducing, whatever drugs that we're studying, haven't shown to have fantastic results. So, talking about Alzheimer's disease, what is it? It is primarily a dementia, memory loss. But since memory and our brains are the most important parts of us, What happens with the memory loss is we also lose our personalities, we also lose our behaviors, we also lose our checkpoints where we know how to control our impulses, how to control our behavior patterns, and that's what happens in Alzheimer's. And it's not the fault of the patient, it's not the fault of the caregiver, but an unusual amount of burden is placed on both, and society in general. If you look at Alzheimer's disease, when it is diagnosed, it's usually in the mild state already. So there are different stages of Alzheimer's. It's been known to have 4 stages. They're not discrete stages. They kind of meld into one another, but you can tell when one person has gone from one stage to the other. You can think of it as mild, moderate, or severe, or you can think of it as stages 1, 2, 3, and 4. However, between 7 to 9 years before diagnosis, people will show changes of memory which are not even recognized. And we're starting to see that more and more being recognized. So we call that mild cognitive impairment. Know that everybody who has mild cognitive impairment does not necessarily go on to have Alzheimer's disease. And mild cognitive impairment and mild Alzheimer's or memory issues can be because of stress, because of too much on your plate, because of sleep deprivation, because of depression. So just because all of us forget where we left our keys, or forget where whether we locked the door or not, or forget, oh my God, I know this person's name, what is it? Doesn't mean we all have Alzheimer's. Know that, as aging progresses and our body and our cells age, the mind also ages. And as we get older, we are more and more likely to have memory issues, what we used to call senile dementia. And now everybody says, oh my God, I think I have Alzheimer's. People who are 15 and 16 are saying that, which is, not really true. But it's just a catch-all phrase now. So it shouldn't really have the stigma that it does. So what are the different stages? What do they entail? So mild Alzheimer's dementia is simple things: missing. Where did you keep your keys? Where did you put your purse? Where did you lock the door or not? So mild memory problems, sometimes some word finding difficulty. You see someone, you say, okay, I can't remember the name of this person. So that would be the mild, stage 1. The moderate will become more of these issues. People will start having word finding difficulty. I can't find the word I want to say. It'll come to me if I'm not so stressed, or give me a couple of minutes and I'll get it. As that becomes a little more progressive, people start forgetting, more and more things. As it comes to the moderate stage, might forget names of closer relatives, friends you haven't seen in a while, and then soon may forget the names of your own daughters or your sister, may confuse them. Also, when that happens, you can also have issues of, say, some balance problems, some wasting that occurs because you also lose muscle mass, appetite changes. And across the board, there is this thing called apathy, where people don't have much initiative. You might see somebody with the dementia sitting, not wanting to do much. This person used to be such a go-getter, not so much anymore. This person could take a look at anything mechanical, any appliance, and could fix it. Now they just take it apart and don't know how to put it together. Or this person could write these great poems or write these great stories. Now they're having word-finding difficulty. This person used to be this great psychologist who taught at Harvard, who could give these talks on semantics, the theory of language. Now they're having word-finding difficulty. So these are some of the changes that occur. And these changes occur because of neuronal degeneration. The neurons start to die. Why do they die? We don't know yet. But that's what really happens. And then as it goes on, as it progresses further, you might have changes of, balance, changes of sleep, sleeping more through the day, not sleeping quite as much at night, having intermittent naps and then pacing at night. About 30% of people in moderate to severe dementia may have delusions. A cushion sitting on the sofa looks like a little dog or a cat. A basket lying there can look like another animal. Those are delusions where certain things that are kept are misrepresented in your own mind. And then you look again, you say, oh, it is a cushion. or hallucinations where there's nothing but you see people, or animals, or puppies, or small children playing. A lot of these are fun hallucinations. Some of them are scary. So it all depends on what kind of hallucinations someone might have. So these are the different types of changes you might expect. And as it progresses further, there is an erosion of the personality. They become more and more bedridden, less able to do things by themselves, more dependent on other people. They may need to get, insight into, don't you want to brush your teeth? Little things like, maybe you should go take a shower. Or, you forgot to tie those shoelaces, you might fall. So things like that. Or you might see changes of, they become more stubborn, difficult to have the proper judgment. No, this is not the time to go out. Wandering out in the middle of the night. Or we may try to stop them from doing that, and they may not want to stop, because to them it's 2 a.m. So what? It's time. I'm bright. I'm ready to go out. I'm ready to take a shower. So those are the kind of changes that can happen. So I just wanted to show you a pictorial representation, which actually Heather, I found out, has the same slides. So it looks like it's a pretty evocative description in an artist's life, a German artist who actually was diagnosed with Alzheimer's. And I just wanted to go over the slides with you where initially this artist, who did a lot of description in his paintings with a lot of vivid, bright colors, slowly there's an erosion of that thinking process. And it's a very evocative set of slides or paintings. So this is the artist, William Utermohlen. And this is the first picture. It shows a winter scene where you can see a living room, and outside you can see the landscape is quite barren with snow, no leaves on the trees. But within this very cozy living room, you have these fantastic colors. You have this fantastic detail. On the mantelpiece, he's showing changes, little objects being put there. He's got the couch with this vivid pattern. He's got the bowl of fruit up front, and just, the dining living room just comes alive right here. A few years later, here's a self-portrait, and unfortunately it has a saw there, so I think he has an idea of something like a specter waiting to fall on him. And you can see the colors are not quite as vivid, the details are not quite there. And you can see from his eyes, whether it's despair or sadness or just the expression is pretty pensive there. And this is when he has more advanced change, where you can see that he's a shell of his former personality. And so again, I don't want you to take home from this that everybody's going to get it, but I just thought this was a very evocative transition where it just gives you pictorially what the whole talk is really about. It's a slow and steady erosion of the neurons, the memory, the personality, the character. So I already talked about the stages of Alzheimer's, and I'll go over a little bit about what's new in diagnostics and what's new in therapeutics. But basically, we don't have a cure yet. That's the bottom line. But we're working rapidly. Like I said, there are 400 in phase 3 trials, and some of them will come to fruition. So what is it? It is a progressive neurological disorder. And the projection is that currently there's about 5 million, except that I just read somewhere in the Wall Street Journal a recent article that came out last week, 36 million actually, and projected to be about 60 million by 2050. About 7.7 million per year new diagnoses of Alzheimer's. And aging is one of the things that causes an increase in progression. So as our population ages, that's why we're also going to see more diagnoses. And it is the fourth leading cause of death in developed nations after heart disease, cancer, and stroke. About 7 to 9 years is the life expectancy in people who have this diagnosis, but about 3% live up to 14 years after. It's actually the deterioration of the general function, pneumonia, other infections that cause the death. It's not because of the disease. The disease doesn't kill per se. And the cost of care is about 600 billion. So I guess I'll have to change this. This again I saw yesterday in this Wall Street Journal article. And you can see out here between the pictorial of the brains, it's primarily a degeneration. On the right side of your screen, you'll see the diseased brain, and on the left is a healthy brain. The healthy brain is robust. It's got good gyri or mountains, good sulci, but then the degenerated brain shows a lot of shrinkage, and that's what happens. And here it's a cross-section of the same thing. You have mild in the middle and severe Alzheimer's at the bottom. So what are we thinking is the cause? We don't know what causes this to happen, but we think that there are two basic mechanisms. We have this abnormal protein that is laid down in sheets called amyloid plaques at the bottom. And the other thought is these tangles that occur from a protein which is associated with the cellular tubules called tau. Tau is tubule-associated protein. And there is a problem with both of these. And what happens is that they get deposited in the neuron, in and around the neuron, and therefore they further deteriorate or degenerate the neurons. So there are different pathologies that are being postulated, as you can see, this whole list. And the amyloid is what we have been focusing on for the last 20 years, 30 years, and they're trying to work up different amyloid drugs. These drugs have been either to clear the amyloid. They tried to do that with a vaccine in 2002, but it had to be taken off the market in a couple of years because the people who got the vaccine actually showed some brain swelling, about 6 of them. And what they found is that in mice, as well as in pathology of these humans who had passed away when they got the vaccine, that the amyloid actually decreased. Amyloid, if you think about it, is like sheets of abnormal protein that sort of go across the brain. So they actually found that the vaccine decreased the amount of amyloid. But unfortunately, it did not decrease the degenerative process. The degeneration of the neurons still continued. But they're still working on other vaccines. They thought that maybe the swelling of the brain was because of the adjunct of the vaccine. So they're trying to purify the vaccine further. So that's one way they're looking at treatment options. The other way they're thinking of is an amyloid antibody, bepemuzab, and a couple of other antibodies to try and reduce the amyloid. Again, this is all works in progress. The inflammatory theory, we all think that some kind of inflammatory cascade comes about in all the diseases in our body, oxidative stress causing inflammation. And that's what causes the dementia, the degeneration of neurons. So they actually did some studies to see if anti-inflammatories such as ibuprofen, other non-steroidals, seem to show any benefit. They haven't found major benefit, although they have seen that people who are on long-term ibuprofen seem to have a slightly reduced risk of Alzheimer's dementia. But the problem is you have those other problems with these medicines, kidney disease, stomach issues. So it's not exactly benign treatment. Abnormal phosphorylation of tau, this is that tubule, microtubule-associated protein that I told you. It disrupts the tubules within the neuron, so it disrupts the mechanism of substances moving within the neuron. And so they're looking into tau and anti-tau treatment to see if that would help with the treatment of dementia. Still working on it, nothing so far. And then, of course, free radical toxicity, disturbed calcium homeostasis, etc. One of the things which is in the bottom part of it is cholinergic dysfunction. So the thought is that because of degeneration of neurons, what is happening is that the synaptic transmission, the transmission between neurons, is not going as well. And to have that synaptic transmission, there is a neurotransmitter called acetylcholine. choline. So the way that the nerve cells transmit from one to another is you have electrical impulses that go through the axon, which is the nerve fiber, into the nerve cell, and then to go into the next neuron, there is a sac. In that sac, you have acetyl and choline. It's in its own pockets. So when an electrical stimulus comes, the acetyl and the choline drop into the sac and combine together to form acetylcholine, which transmits the message, which converts into electrical activity and goes on. What happens is, per this cholinergic theory, is that the acetylcholine is either not sufficient or not there long enough for the degenerating neurons. So by the time the impulse is coming in a wayward way, the acetylcholine has already gone back into its packets or pockets. And so what we're trying to do with these Alzheimer's drugs now is trying to keep that acetylcholine a little bit longer. So if there are any wayward impulses coming, they have the ability to go across. That's what these drugs are doing, which are available these days. These are the Aricept, Razodine, and Exelon. They have chemical names, but I'm not, I'm just telling you the usual names. So these three medicines are supposed to keep that acetylcholine longer. How do they do that? They're acetylcholine esterase inhibitors. So when the acetyl and choline drop into the sac and they come together, they're supposed to cleave away and go back into their sacs. That enzyme which cleaves them away is acetylcholine esterase. So these medicines prevent that enzyme from working quite as quickly. It does work, but that's what they do. So these help promote neuronal connections a little bit longer, despite the degeneration of the neurons. Did I make that clear? Sort of, kind of? Okay. A little like mud. Okay. Basically, the acetylcholine esterase inhibitors, these medicines are preventing that chemical, are making that chemical transmitter stay longer. So if there are any wayward impulses or impulses that are taking longer to come because of degeneration of the neurons, they have a chance to get through, pretty much. That's what it's doing. But it doesn't prevent the further degeneration of neurons, and that's why, despite these medicines, they're not cures. They're not continuing to be beneficial. That's why people degenerate despite these. That's why a lot of times when you take these medicines, you don't see a real response. It's not like you take a Tylenol, your headache goes away, you know the Tylenol worked. This is more like vitamins. You take vitamin C, your cold lasted for 2 days versus 5 days of your neighbor, you're like, aha, the vitamin C worked. You don't know if it worked. So I commonly refer to these as brain vitamins. They're not. They're medicines, but you should treat them as brain vitamins. And that is why after a while they're not very effective. Yeah? Question is fish oil effective? Right? And fish oil has not been proven in huge studies to be effective. However, having said that, one of the postulates of what causes Alzheimer's is the metabolic syndrome, which is hypertension, diabetes, high cholesterol, and coronary artery disease or heart disease. So fish oil helps with that. So we think and we hope that some way fish oil is helping. Now that's a very unusual case. Most people who are given high doses of fish oil who are in coma don't have that improvement. So I'm glad that child or that young man did, but that's not the norm. And maybe there were other factors that helped him, and fish oil was just the more evident factor. But no, the answer is big studies. The latest thinking is fish oil has not helped Alzheimer's per se, but it is supposed to help with heart disease, and a lot of heart problems can cause problems of dementia, and therefore it can help. Okay, so there are other norepinephrine, serotonin dysfunction. I don't think you really need to know about that, but I just wanted to put it across that these three medicines, what they do is they have the cholinergic effect. There is one more medicine called Namenda, and Namenda is something that works on a slightly different neurotransmitter but does a similar thing. So a lot of times what happens is we give Aricept, Exelon, or Razodine, one of these three with the Namenda. Now, what I usually say is they're not additive. the benefit is not going to be 2x, it might be 1.2, 1.3x. Some people want to take these medicines because they want everything there is available. Other people say, just give me one, I don't want too many chemicals. Either way, you wouldn't go wrong, but at least go on one of these if you have any memory problems, because at least it'll help improve the synaptic transmission. So the other question that arises, and I'm not adhering strictly to these slides, by the way. I think there's too much information. I just want to make it clearer. So the other thing that comes up is, of course, a person who has Alzheimer's dementia worries about their children or their grandchildren. Will they get it? Will they also suffer that way? And the prevalent thinking per research is that only about 10% of it is familial and 90% of it is sporadic. And those numbers vary depending on which study you're looking into. Bottom line is that most likely they're not going to get it because you got it, but it's because of aging, genetic, other factors. So they may or may not get it, but they don't have to get it. That's the bottom line. Okay. It's more prevalent in every age group, and as you go up in age, it says the incidence doubles every 5 years, up to 90 years. So the thought is that about 50 to 60% of people in their 80s and 90s will have some memory problem. Is it Alzheimer's? We typically term it Alzheimer's because more than 50% of the dementia is Alzheimer's, going by the plaques and tangles in the brain. It may or may not be. If you really wanted to know, or your family wanted to know, autopsy is the way to do it. I would not recommend brain biopsy for that. Okay? All right. And there are certain factors, the ApoE mutation, as the bottom of the slide. The people who have that seem to have a higher incidence or higher likelihood of getting Alzheimer's. Do we send out tests for this? That's very individual, but let's say I'm in my 40s and I get this tested, and let's say I have it. What am I going to do about it except worry? And so the question is, unless I had a cure that was so specific to Alzheimer's that if I found out early it would be beneficial, I don't really tell my patients or their families to look into this. As time goes on and we get some markers and we have treatments, it may be worthwhile, but a lot of people still may not want to do it. The question is, it's probably worthwhile to know so that they're not driving. Driving is such an individual thing. There are people with mild Alzheimer's dementia who are better drivers than people who don't have it. I usually send people to the DMV. It's a multiple whammy for patients. Here they get this diagnosis, and automatically you take away their driver's license. Not only are they devastated by the diagnosis, they're devastated by the loss of independence, where they could still be independent. Also, how do I know for sure it's going to progress in a downhill course? Mild memory problems may just remain mild. So unless the family comes and tells me, I'm talking about mild, by the way, I'm not talking about moderate and severe. Unless the family comes and tells me, my husband or my brother or my father is making these very many mistakes, or not showing good judgment in driving, or is very impulsive in driving, I'm going to sort of not take their driver's license away. I might send them for an evaluation. I would send them for an evaluation to DMV because I want to see how they're driving, and I can't do that sitting in my office. And so, yeah. So the comment is that for mild Alzheimer's dementia, the doctor reports to the DMV, and the DMV will contact you for the special test. It does and does not always happen. The DMV also has things that fall through the cracks. So sometimes I will make sure that I send the referral to occupational therapists, certain occupational therapists, who will do the driving evaluation. So it all depends on a scenario by scenario, case by case. But yes, you're right. Legally, neurologists are supposed to let the DMV know, inform the DMV for those instances where you think the driving is going to be a challenge or a problem. The comment is that the sooner you find out, the sooner you're able to take the medicine, and I absolutely agree with that. And so here we come to the diagnosis of Alzheimer's. And you're absolutely right, because if you're going to preserve the functioning of the neurons, you want to preserve them sooner rather than later. And so the thought is that Alzheimer's dementia might be a downhill course like that, and if you take the medicine, and these medicines help decrease the rate of decline by 30% max. So if you take the medicine early on, the slope may be this, and eventually you're left with this much memory. But if you take it later on, the 30% slope is only that. Is that clear? Did I make that clear? Yeah. So yes, your point is absolutely well taken. The sooner you know, the better you can start on the medicines. Okay, coming to the diagnosis now. So the main diagnostic categories are not these blood tests and CSF studies. The main diagnosis is via neuropsychological testing, MRIs, and you want to rule out any kind of treatable conditions. And I'll go over each one of these. So when somebody comes to me and says, I have memory problems, I can do a battery of tests. The most simple one that we do in the office is called the mini mental status exam. And this is a set of questions that talk about orientation, recall, registration, short-term memory, construction, reading, writing, and naming abilities. So it's a 30-point score. And in minimal or mild cognitive impairment, mostly it's not positive, it's negative. In other words, you get 30 out of 30. In mild dementia, you may get between 26, 27 to 30. Moderate might be 18 to 26, and severe may be less than 18. And everybody has a different range in this. But the point at issue is that what we see or might see is just some short-term memory recall issues. So I give 3 words, they may remember 2 out of the 3, they may remember 1 out of the 3. And you have to remember, it's in an unusual setting. You're sitting with the doctor, who you're probably just meeting for the first time, and a relative, both staring at you while you're supposed to come up with the answers. It's a pretty tough situation. But having said that, if you didn't have any memory problems, you would be able to come up with it in a few minutes or so. And I will give cues. Okay, let me give you a hint. This might be it, or it's a type of this. So that's the first step, the mini mental status exam. And then what we do is MRIs. MRIs are typically done to evaluate for any kind of atrophy or shrinkage of the brain. The shrinkage may be typically in Alzheimer's seen in the temporal, parietal, and frontal lobes, which are behind the ears, on top of the head, and the frontal lobes are in front. These are the 3 areas where Alzheimer's seems to be affecting the brain the most. In other words, atrophy occurs. And the temporal lobe is where you have the hippocampus, which is the site of memory, short-term memory. And so that's what happens. You lose your memory. That's how it comes to the forefront. So the MRI and the blood tests that we do is to rule out any kind of thyroid problems, any kind of B12 deficiencies, any other kind of systemic diseases that might cause issues. A lot of times it may be depression or stress that I'm looking at. So it may not be Alzheimer's dementia. It may be because of all of these. So these are all the rule outs. Sometimes, rarely, we'll see a tumor there. Sometimes we may see a lot of strokes. So these are the changes that we can see. If there are a lot of strokes, it's not going to be called Alzheimer's per se, although there may be Alzheimer's changes as well. Now, what are the other tests that can be done? There can be SPECT scans, and there can be PET scans. And these are great in the research institutions. They're not that readily available, although Medicare did approve a PET scan called PET, which is beta amyloid PET, which talks about those amyloid plaque sheets that I was talking about. I tried to get it the other day and I was not successful. So it's not that readily available. However, if we do the PET scanning, it can rule in about 86%, but more importantly, it can rule out about 92% of Alzheimer's. So if you really want to know, that is a pretty good test to do. The other test, which is pretty good, which again, I'm not able to get very frequently, is the neuropsychological testing. It is done by specific neuropsychologists. They're not just psychologists, but neuropsychologists. And it's a very involved test, can last up to 3 days. And that goes over how much memory have you lost, which dimension have you lost it in? Has it been in mathematics? Has it been in construction? Has it been in verbal memory? Has it been in semantics, etc.? And that gives an idea, more focused idea of what memory have you lost? What type of memory have you lost? How much of there is depression? How much depression is there which is causing the memory loss? So it's a pretty good test to have, but like I said, it's expensive, between $5,000 to $7,000, and most insurances don't like to do it. But you can always, and also it's hard to find neuropsychologists. But anyway, that's another test that can be done. These blood tests that are now coming about, which are blood tests specifically looking for the amounts of tau and amyloid in the brain and in the blood, as well as other proteins, about 18 proteins that are being looked into. Again, they are more in the testing phases. They have not become readily available commercially to everybody. And also, even if they are available and we prove it, apart from giving medicines that we give anyways, it doesn't, there's no specific medicine that I would give for Alzheimer's and not give for anything else. So to me, I would rather give the medicine to anybody who has memory issues than to wait for these tests. Clear so far? Okay. So I already talked about this. There are different kinds of MRIs. There's this functional MRI that tells you how much the brain is working. And then there are these structural MRIs, which we do. And also there are MRIs that actually look at the amount of atrophy or shrinkage of the brain. They're more used in research protocols. Okay, so these are the ones that, the medicines that we were talking about. Cognex is the fourth medicine. It was the first one to come out. It's a 4 times a day medicine. It was showing some liver changes. Initially in the 1990s, that's what we used, but we really rarely use it now. The other 3 are quite used. The Aricept is the more commonly used one. And then the Namenda is the other one that I said had a different mechanism of action. And then they're talking about different other things. So I just want to stress on 1 or 2 that everybody has questions about. One is the ginkgo biloba, or the ginseng. The other is caffeine or coffee. And the third is hormone replacement therapy. So hormone replacement therapy, the thought was, you know, because if you give estrogen to an aging woman, maybe it improves the memory. However, they've shown, as we saw in the big initiative, women's initiative, that it's bad for other kinds of problems. So nobody's giving hormone replacement for Alzheimer's. Number 2, ibuprofen I already talked about. Caffeine. There are some reports that say, or case studies that have come out, that maybe 3 to 5 cups of coffee in midlife onwards is supposed to decrease the rate of Alzheimer's in 65%. I can see Paulette there going here. That's what 3 to 5 cups of coffee might do to people. But just a thought, am I recommending coffee? No, I'm not. I'm not saying that you should go into that. Just as I wouldn't say take lots of alcohol to prevent heart disease, because then you have other issues that come about, right? Cardiovascular risk factors, pretty important. These are hypertension, high cholesterol, diabetes, and coronary artery disease. The metabolic syndrome, which overall for your general health you have to improve, and so you should. What else? These are just lots of yes, please. Question is, can I say something more about ibuprofen? So the thought was that, as in everything else that degenerates in the brain, there is an inflammatory cascade that comes about. Ibuprofen and such medicines are anti-inflammatory medicines. So the thought was that why not give an anti-inflammatory medicine? And they found that people who do take ibuprofen on a regular basis, people who have arthritis and other issues, seem to have a lesser incidence of Alzheimer's dementia and other dementias. So the thought was, should we use that as a therapeutic agent? But big studies have not shown it to pan out. So am I recommending that you take an ibuprofen a day, just like we say take an aspirin a day? The answer is no. It hasn't been shown to pan out. If you take aspirin and ibuprofen together, it reduces the efficacy of aspirin. And we think aspirin is important for the heart and for the brain. So I would rather you take the aspirin than the ibuprofen. Yes? So there are a lot of anecdotal references to ginkgo and ginseng, both supposed to help with what they thought was it improves the brain it improves the vascularity to the brain, improves the blood supply to the brain. If you improve the blood supply, likely your memory should improve because it provides more oxygen to the brain. They did a lot of studies on that, and they didn't find it to pan out. Also, if you take ginkgo with Coumadin, which is a blood thinner, your risk of bleeding increases by 4 times. So it's not necessarily a healthier alternative. Should you not take it? You know, if you're not taking too many other medicines and want to take ginkgo or want to take ginseng or want to take coenzyme Q10, I never stop people from doing it because maybe it'll help a little bit, but not heavy doses. What are heavy doses? Well, nobody's really done major studies, but whatever's listed on your medicine jar would be, don't take more than that. They also did this whole initiative on vitamin E because the thought was it's an antioxidant, and so it helps with the inflammatory cascade and reduces the free radical damage, which causes these degeneration processes. They didn't find that vitamin E was proven to be helpful in dementia. And sometimes if you take too much vitamin E, you can have bleeding issues also. So too much of anything, and again, I can't define the too much. It's different for different people. But if you wanted to take these medicines, these supplements in moderation, I don't see a reason why not to. Know that worst case scenario might be that you're basically throwing them down the drain. You know, they're not helping. Okay, what are the other non-medical ways of treatment of Alzheimer's or dementia of any sort? We're learning about, you know, mental stimulation, crossword puzzles, Sudoku seems to be, oh, everybody should do that. Some people tell me, but I hate those things. Why should I do that? No, you shouldn't. Don't do something you hate. So do something that improves your interaction, I would say. So I tell my patients, if you're reading a book, talk about it. If you're watching a movie, talk about it. Don't be a passive observer. Don't be a passive reader. Talk about these things. Somehow that seems to stimulate the mind, and that seems to get, you know, the thought processes going. They say learning a new instrument. They say learning a second language later on in life. Anything that'll charge your brain up, anything that taxes your brain to learn and make new connections, because the brain is always making new connections, is a good thing. So keeping your brain active, keeping a social interaction going. People, they have found that, they did this whole nun study where they found that those nuns, what they did was they used nuns as a cohort in Minnesota. And because it was a cohort with very similar experiences. It was a very controllable experiment. And they found that those nuns, they went back and looked at their writing, and they found that those nuns who had very sparse writing, those nuns that wrote letters which were short, pithy, to the point, versus those whose letters were long, filled with detail, filled with a lot of words, the ones whose letters were short seemed to have more of a propensity to develop Alzheimer's. Those that wrote long, pithy letters, those that spoke more, those that interacted more, seemed to have less Alzheimer's dementia incidence, and also those that had it, their dementia was not that bad. So it's, you know, how much brain you use, basically. That's what it comes down to. The other thought, which is true of everything, is exercise. Exercise seems to improve your circulation, seems to get the endorphins going, and seems to be putting up other or increasing other substances within the brain, within the body, which is probably protective, which we don't know yet. So exercise is the other thing that is felt to be very useful. Good diet. Good diet is, if you have a better diet, you're less likely to have the metabolic syndrome, the blood pressure, the cholesterol, the sugar issues. So better diet is always good. So these are the things which are the preventatives of Alzheimer's or any other problem. How can seniors exercise when they have arthritis in their joints, they're in pain all the time? It's easy for me to say, go out and exercise. I know. Well, You can have other forms of exercise. You can just sit in a chair. You can mobilize your joints. You can do like joint rotation exercises, number one. You can do light weightlifting, which helps actually calcify your bones better, so decreases osteoporosis. Exercise doesn't always have to be go out and walk. Let's say their knees are hurting. To strengthen their quadriceps, they can do cycling. They can do rowing, where you don't have to use your knees maybe to that extent. I don't know, depends on what they can do, but there are different ways of doing it. I think you have a suggestion, yes. Silver sneakers at the 24-hour fitness here, 10:15 to 11:15 Tuesdays and Thursdays. Monday and Wednesdays. And then there's Aquasize, yeah, water aerobics, which is present in the other, well, it's present in a lot of gyms. The Silliman Center has it, 24-hour fitness in Irvington has it, yeah. So the thought is that her mom has a pretty tight carotid artery, and they're recommending surgery to open it out to see if improving the blood supply will improve the memory. There's no guarantee of that, number one. But the carotid artery cleaning is more recommended so that it doesn't block off and cause a huge stroke. And so the memory is the lesser of the issue with the carotid stenosis or narrowing. And I don't know the details, but you know, that's really why we recommend carotid artery cleaning, endarterectomy, stenting, etc. Question is, he has pain everywhere, circulation is okay, but the thought is it might be a neuropathy or nerve problem. Can the nerves be improved? And the answer is that neuropathy sometimes is painful and progressively painful. And there's nothing we can do other than improving, taking vitamins, B vitamins sometimes help. Sometimes medicines that we use for neuropathic pain can help. Sometimes nothing helps, unfortunately. So you're not the only one with the neuropathy. And it's too bad that we don't have too many medicines, but we do have some medicines that can provide some relief. Also, what happens in people who have chronic pain is that you are so caught up with the pain that the memory seems to be not doing so well because you're so focused on the pain. And so it's not a true, I'm not saying you have it or not. I'm just saying that can happen, memory issues can happen. Relationship between thyroid problem and Alzheimer's. Well, thyroid is a hormone that is produced from a thyroid gland which is in the neck. And it causes a myriad symptoms, which can be, among other things, a lot of fatigue, lethargy, slowness of movement, slow heartbeat. And the thought is because of it reducing the metabolism in the rest of the body, it also reduces the metabolism in the brain. So if you improve the thyroid, you will improve the memory problems. Okay? Anything else? All right. Thank you very much for coming, and I hope you got to answer your questions.
So we understand what the disease is, and we understand kind of how it affects the person that's been diagnosed with the disease. I want to talk to you about how it affects family members and how do we prepare for the journey. So we can think of the journey as kind of as like a book, a great novel. There's a beginning, there's a middle, and then there's an end, right? And these are actually all books written by people that have Alzheimer's disease or had Alzheimer's disease. There's a lot of resources out there for family members and people with the diagnosis that I'll talk to you a little bit about at the end of today's presentation. So this is this picture that that the doctor was talking about that we share. So I'm not going to talk about this with you. But not only does a person with the diagnosis, the person that receives the diagnosis is the only person that's affected by the disease. It's an entire family unit, whether it's an adult child, whether it's a spouse, whether it's a sister or brother, everybody's affected by this disease. And as a person progresses through the stages of the disease, you do as well. And the person's needs are also going to need to be taken into consideration. So they're going to need a companion, right, as they go through this journey. So what does that mean? So those of you that have been caregiving for somebody with the disease, have you noticed that you kind of are on beck and call 24/7? That you know about the disease? Those of you that know about the disease, are you kind of figuring out this is kind of a 24-hour job? Absolutely, absolutely. And oftentimes we find ourselves doing things that we never did before. For example, I work with a lot of family members where one of the spouses was taking care of all the taxes. And that's the spouse that ends up with Alzheimer's disease. And the quote-unquote well spouse, right, because I'm sure you have health problems as well as you're providing care. But the well spouse had to learn new skills, right? You had to step up and say, whoa, where's this paper? Where's that paper? How do I do my taxes? Not that you had to do your own taxes by yourself, but there's a lot of, the learning curve is pretty high. Did everybody hear what she said? That he just started making, it starts off as these little mistakes that, that are okay, sort of, that the person is able to kind of pick up and, carry on, but eventually that they're not really able to complete that specific task anymore. And so, we take on a lot of the roles that are the person with the disease had once done, or we add on to what we're already doing, right? And so oftentimes what happens is that we forget to blame the disease for the problems that we're experiencing. So we don't want you freaking out. We just want you to be informed. And if you have, Dr. Singh talked about some of the risk factors. If you have a parent that has Alzheimer's disease, or if it runs in your family, or if you have all these high risk factors, these are things you should be concerned about. But that doesn't necessarily mean that you have Alzheimer's disease, okay? But it's something that you can talk to your doctor about. And so it's important to have a really good working relationship with your doctor. So if you're scared about it, I would say talk to your doctor, or you can even call the Alzheimer's Association, or you can go to a support group and talk about your fears. It's important to reach out for help, and oftentimes we don't, right? Oftentimes we keep a lot of these things private, right? We don't share kind of our fears with family members. We don't share our fears with strangers. It might be easier to share with strangers than it is with family members, especially when you know that you're never going to see that person again, right? So it's really important to have kind of a working relationship with a physician, or even attending a support group to kind of talk to people about your concerns. Did you have a question? No? Anyone? Okay. So kind of back to this whole kind of self-care, right? It's about taking care of yourself and having those fears. But it's also about understanding the journey that you're on as a caregiver, as a family member. Whether you are providing 24-hour care, you live with the person, whether you're a long-distance caregiver, maybe you're taking care of a parent that lives back east and you live here, you're still a caregiver. It doesn't necessarily mean that you're providing one-on-one physical care. If you're fretting about somebody, you're a caregiver. But it's also really important, kind of the first step in this journey is understanding that everything that's happening, that the problems that the person is experiencing, whether it's taking their medications and then 5 minutes later taking their medications, or not being able to pay a bill, or asking you when dinner is 15 times in a row, or forgetting when the doctor's appointment is, or even not being able to tie their shoes, all these things are because of the disease. It's not really about the person, it's about the disease. And if we keep telling ourselves that, we're better able to kind of cope with the demands of the changing behaviors. Does that make sense? Okay. So just a little bit about caregivers. I like care partners. I would like to view it as a partnership. Granted, at some point, you'll probably be doing 98% of the work, and the person will be doing maybe 2%, if that. But it is a relationship. It is a partnership. And typically, what we see is that the primary care partners tend to be women. They tend to be spouses or adult daughters. Typical age range is from 50 to 70. So we get the sandwich generation up until retirement. And the sandwich generation is typically a woman who's working and has small children or young children or teenage children at home. Average hours of caregiving, I hear 24/7. You know, when I did a lot of research and I would ask, that was one of the questions, how many hours per week do you provide care? 24/7. But typically, through research, what we hear, it's about 70 hours a week. If somebody's working part-time, it's about 40. If somebody's not working, it's 24/7. Again, you might not typically be or actually be doing physical care. You might not be paying the bills, or you might not be providing, cooking dinner, or making calls, or making appointments, or things like that. But the very fact that you're fretting about, what am I going to do next? When is the next shoe going to drop? Right? That's all about providing care. Right? Because you're so involved in thinking about the person with the disease, oftentimes you lose focus of your own needs. So I love quotes, and as you probably see, I love pictures. I like breaking things up. This is a quote by Joseph Campbell. We have not even to risk the journey alone, for the heroes of all time have gone before us. The labyrinth is thoroughly known. We have only to follow the thread of the hero path. I got into this, I don't want to say it's a business, but this field, because I've learned more about the disease through family members experiencing the disease. And that oftentimes caregivers don't get the recognition that they deserve, and need to. You are heroes. You are nurses. You are doctors. You are cruise ship directors, right? You're activity directors, you're chauffeurs, you're pharmacists, right? You're taking on all these little duties. You're financial analyst, right? By paying the bills and doing the taxes, you take up all these different roles in order to provide care. You are a hero. And if nobody ever tells you that, you need to tell yourself that, because oftentimes we go unrecognized. So let's talk a little bit about the journey. As I said in the beginning, I kind of look at the journey of caregiving in these 3 stages: preparation, on the road, actual nitty-gritty of it all, and then the aftermath, when your caregiving journey is over. So in preparing for the journey, even you can use this talk to think about caregiving in general, whether you think you're going to be taking care of your spouse, or whether you think you're going to be taking care of an adult, of your parent, or even a child that has an illness. So it doesn't really necessarily need to be just about Alzheimer's disease. So in kind of this first stage, the way we were, kind of like the normal living, where you are now, right? You're kind of in the Shire, you got all the sunflowers, everything's nice, maybe you're paying the bills on time, maybe not, but things are going fairly well and you're able to kind of manage, right? And then you start kind of noticing changes, maybe in yourself, maybe in your loved one, and sometimes those changes are, they're little, honey, where are the keys? Or honey, did I pick up the dry cleaning? Or honey, where did I park the car? Right? These things are kind of normal, everyday nuisances that happen to us. And then they start becoming more frequent, right? Your husband's always asking you where the keys are. Or where did I put my wallet? Or where is my doctor's appointment? And it's just more frequent and more kind of repetitive. And this is that you're observing these changes. And you finally get up the nerve to go to the doctor, right? For how many people does it just take you months and months and months to make that doctor's appointment? Nobody? You don't sit there for 6 months and say, well, maybe it's this or maybe it's that. You automatically go to make that doctor's appointment? Oh, yes. So you're the 6-month typical human being that calls it something else for a long period of time, right? So after you kind of figure out that, no, it's not A, B, C, or D, right, you go and make your doctor's appointment. And finally, you have a name for all this weird, what you think is weird behavior, right? And then you sit there and say, okay, what's involved? What am I getting myself into? What does this mean for me right now? What does this mean to me for the future, right? Because unfortunately, this is a disease that is not going to get better, right? There's no magic cure. As much as we wish, as much as we strive for, there's no cure for this disease, and it is only going to get worse. You're going to find yourself doing more things, and more things on a regular basis. And you make the decision to take it on. A lot of times I'll hear spouses say, well, I said in sickness and health, I said I was going to do this, I'm going to do it no matter what, and that's great. But it's a choice, right? You don't have to. And I'm not saying that not doing it is good or doing it is bad, but we make these choices to do it, and a lot of people don't. And so when you step up and say, yes, I'm committed, I'm going to stay, I'm going to do this, I'm going to do it as long as I can, and I'm going to learn as much about the disease as possible so that I can be a companion to the person that has been diagnosed. Okay? So the kind of what am I getting myself into? I mean, it's emotional energy, right? It's actually the physical energy of having, if you have somebody that wanders, or if you have somebody that's not able to bathe themselves, or if you're having to cook meals all the time, there's the physical energy. It's an expensive disease, right? I think Dr. Singh had a slide that said from 6 to 12 years? 9 years from time of diagnosis. That's a long time to live with a disease. And if you're taking care of somebody that's not able to do some of the, what we call activities of daily living, the dressing, the bathing, the feeding, the using the bathroom, taking care of the finance, or being able to get out of bed, or doesn't have any mobility issues, and if you're not able to do it, you're also going to have to probably hire somebody to come in and help, or you're going to have to quit your job and take on that role. So it does become extremely expensive, and oftentimes, like you just mentioned, your dad feels like he needs to do it all, and oftentimes they do. The care partner does it all, but the problem is that oftentimes the care partner thinks that they're the only one that can do it, right? And doesn't allow a lot of support around services coming in or even going out to services, that oftentimes the care partner feels alone. And when you're there 24/7, it's very easy to feel very, very alone. I skip ahead and I'll go back. So kind of these emotions around caregiving, right? The burnout, right? Where you're kind of running on empty. But if you run that way for 6 to 9 years, at some point you're going to be the one that's going to need a care partner, right? Because nobody can really do it alone and come out of it healthy and sane, right? And oftentimes there's anger, right? If you're dealing with a lot of difficult behaviors, there's frustration, and then that loss, right? This is not the person that you married, right? And then watching them go through this horrible disease, or watching your parents go through this disease. There's a lot of not guilt, but there's a lot of kind of grief around this disease. And it's called anticipatory grief. You're just kind of waiting and waiting and waiting. It's not like Heather ran outside and got hit by a semi and you grieve, you bury me, the end, right? This disease is like this death is carried out for years and years and years, and you're just watching this person disappear from you, right? So all these emotional states, they're not linear in any fashion, right? You're not going to feel this way. Well, maybe tomorrow I'll be happy because Heather said I'm going to feel this, 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 this. These things come and go. They fluctuate. You can feel good one day and then feel kind of really crappy the next day, right? And then you're questioning, did I make the right decision? Am I doing everything I can for the person that I'm providing care for? Why did I yell at him? I know it's not him. I know it's the disease, right? So there's all this kind of back and forth with a lot of our emotions around the disease. So I call this kind of on the road. These feelings start to kind of emerge and come up of kind of the nitty-gritty of providing care. Into the woods, right, with your flashlight, trying to figure out, okay, what am I doing? What's going on? Why is he taking his medication and he just took it 5 minutes ago? I told him when the doctor's appointment is, right? It's like the learning about the disease. So it's a re-education of yourself, finding out as much as you can about what's happening, why is it happening, and how do I deal with it. Right? And there's practical solutions to kind of dealing with difficult behaviors that you might be experiencing. Somebody that doesn't want to bathe, or somebody that always wants to be part of financial decisions. Right? There's practical solutions. But a lot of times, for families, you want a roadmap. No, and that's where you are as a caregiver, right? Because there's no map I can give you that says you are here, and then 2 months from now, you're going to be here, and 3 years from now, you're going to be here, because the disease is so different for everybody, right? There's not a workbook I can give you and say, follow this, go forth, everything will be fine, right? It's a journey, and there's going to be these bumps and there's going to be some real deep bumps for you, and you'll pick yourself up, and you'll figure it out. And you'll figure it out with help from other people. But the important thing is remaining connected, right? And feeling that you're doing good work. You're doing a good job for the person that you're caring for. But a lot of times, care partners tend to be isolated, right? They tend not to go out with friends. And there's only so many times your friends are going to call you before they stop calling to see if you want to go someplace. I find that family members who kind of from the beginning that have already included relatives in the neighborhood and his friends and your kind of inner circle, they're well aware of what's going on. They're more prone to be involved when you need extra help, right? And oftentimes friends and other family members don't understand or don't know what that help looks like and don't know how to offer it, right? Because we all have this preconception of what the disease looks like. Maybe help means, can you just come over and have a sandwich with him? He can't make lunch, but can you help him make lunch and hang out with him? He might stutter on his words. He might repeat the same things over and over again, but all in all, he's pretty much the same guy married. Sometimes adult daycare centers, having the person involved in adult day health programs is great. There's a number in the community. There's one in Hayward. You guys are in this weird location where you can actually go to San Jose and Mountain View, and it's not really too far away. So there's a number of adult day health programs in the area. But keeping the person active is really important, and keeping them as socially engaged as possible. And then sometimes, if somebody's asking you to go out, maybe you do have a friend that says, "Hey, I can hang out with your husband." I know in our support groups, we have a support group here at the hospital that meets the last Wednesday of the month from 7 to 9 p.m. Not quite sure if they do, but I have a support group in Oakland, and what they do is if one of the they kind of pinch hit for other family members. So if somebody has an appointment or wants to go out with a friend, they might come over and watch the person that has the disease, or they'll take the person that has the disease out. So they share some of that burden so that other people in the group can actually have a social life. It's important for you to find ways to be as socially active as possible. Is extremely important. Your number one job as a caregiver, as a care partner, is to outlive the person that you're taking care of. And you can't do that if all you're doing is providing care 24/7. So when you have somebody that can't do adult daycare, there's a in-home support, in-home care workers are really great, where you have a schedule. They don't have to be there 24/7. Most agencies will have a minimum of how many hours that they need to be there a week. Some are even just a day. So that's always an option. But the thing is, what I'm encouraging you to do is start introducing those things early. A lot of times we wait for a crisis to happen before we start seeking out services, and sometimes receiving those services or utilizing those services becomes a lot more difficult when we're in crisis mode. Utilizing those services early when you're not in crisis mode, like so you say, well, I don't need that now, everything's fine, I'm able to manage. That's great. Maybe you can have an in-home care worker come over 4 hours once a week so that they can kind of get used to the person. They know who this person is, the person with the disease knows who they are, and they're trained to kind of provide some of this hands-on care when needed. Doesn't necessarily mean that you need to utilize those types of services right now. So in-home care workers are great, and adult daycare health programs. But you're right, there's only certain things that friends are able to do, that feel comfortable to do. I mean, I know if my neighbor called me, and and my husband was very, very ill, and or their husband was very, very ill, and I was afraid that I don't want them to die while I'm watching them. That's a human fear. And oftentimes it's important to also, sometimes we do go without help. And sometimes it is us 24/7. Yeah, and it can be. I'm trying to offer you alternatives to think about. If knowing what's available now is really important, even though you don't have anybody that you're going to be taking care of, knowing that there's adult daycare, knowing that church groups are available, knowing what they're due, knowing that there's in-home care providers, knowing how much things cost, knowing that there's a support group out there to go to if you so desire, coming to education lectures around various illnesses, whether it's Alzheimer's disease or it's rheumatoid arthritis. Knowing this information is extremely beneficial. So sometimes, and I get that a lot. That's hard because you want to provide compassionate care to the person. You want to respect their wishes. But oftentimes what happens is that what you're asking of that person is to make executive decisions around their care that they probably are not able to make, right? So if somebody's impaired and they're saying, let me give you an analogy. It's like a drunk driver, right? I threw back 5 Long Island iced teas. Does anybody know what Long Island iced teas are? There's a lot of alcohol in them, right? Or I had 5 shots of tequila or vodka or sake, whatever. And I'm, stumbling around in the restaurant or bar, and I'm happy-go-lucky, and now all of a sudden I'm going to take my car keys, and I'm going to tell my husband that I'm okay to drive, right? I'm going to take responsibility and say I'm okay to drive. Clearly, I'm probably impaired, right? I should not be making that decision, but I'm going to put up a fight and a fight and a fight with my husband until he takes the car keys away from me and says no, right? Because in that particular moment, I should not be making decisions. Now, if we apply that to Alzheimer's disease, there's going to be a point where they're really not going to be able to make decisions, or should be making decisions, right? Because it affects not only their health, but it affects their safety, it affects your health and your safety. So oftentimes, you are going to have to be the decision maker, and say, and tell your husband, this is not about you. This is about me. I need this person to come in for me. I know that you're okay to take care of yourself with your fingers crossed, right? Because you don't want to argue with somebody that really is not able to argue with you, or that's rational enough to argue with you. And so oftentimes you have to, what I like to call fiblets, right? Yeah, honey, he's just coming in, or she's coming in. She's going to help me with dishes. She's my friend from church. She's going to help me around the house. Everything's going to be okay. This is not for you. This is for me, right? And oftentimes, that proves to be very effective. If you put it back on yourself, I'm doing this for me. Has nothing to do with you. Everything's fine, right? Fingers crossed. Everything's fine with you. But this is for me. Oftentimes, that's very effective. This is all on your slides, too, about the services in the community. Just a little bit about the resources. So I'm from the Alzheimer's Association. We're just right over the way in Mountain View. We have offices in Lafayette, all over the Bay Area. Again, we have a number of support groups in the community. The one here, again, meets the last Wednesday of the month. We are not meeting this month because of Thanksgiving, I think. If you go online to our website and check our calendar, you can see when all the groups are scheduled. Family Caregiver Alliance is another resource. So is caregiver.com. If you're computer savvy, they have a wealth of information on just caregiving in general. And then the National Institutes of Health, the DEAR, has a lot of great information on research, kind of the medications, what's coming down the pipeline. If you're looking for like kind of more like what I like to call heady information. But the Alzheimer's Association, not only do we do presentation, we actually do family caregiver training classes for professionals and family members. We have a lot of educational programs in the community. We do family counseling. We have early stage programs for people that are in the early diagnosis of Alzheimer's disease or related dementia. So if you want more information, my business card is in the back. I also have some brochures back there for you. But we have a lot of information on our website too. But please feel free. You can call the 1-800 number. You can ask for me, or you can talk to one of our other very knowledgeable volunteers. All right. Thank you.
Heather, thank you.
You're welcome.